Hello everyone, my name is Beverly Quintana and I'm the Communications Manager here at the Association of Asian Pacific Community Health Organizations, or AAPSHO. AAPSHO is a national association of 35 community health organizations, 29 of which are federally qualified health centers, CHCs, serving Asian Americans, Native Hawaiians, and other Pacific Islanders and NHOPI. We are committed to providing you technical assistance, program and research support, and up-to-date policy and advocacy tools that will help improve the health status and access for these medically underserved populations, which is why we're here today. On behalf of AAPSHO, I wanted to thank you for joining us for today's webinar entitled Increasing Access to Care and Improving Health Outcomes, a spotlight on AA&NHOPI serving community health centers. We're excited to present you with information on the role of these health centers in reducing health disparities and promoting health equity. But before I get started, I wanted to review a few housekeeping items and let you know how you can participate in today's webinar. Here we are looking at an example of the Gotowebinar attendee interface, which is made up of two parts. The viewer window, shown here on the right, but maybe on the left on your screen, depending on your browser or computer operating system, allows you to see everything the presenter will share on their screen. The control panel, shown here on the left, but maybe on the right on your screen, allows you to participate in the webinar. By clicking the orange arrow button, you can hide or show your control panel. Please note that all attendees are in listen-only mode and will be muted during the presentation. You may submit questions during the presentation by typing them in the questions field on your control panel, and we will address them during the Q&A session held after the presentation. Today's webinar is being recorded, and you will receive an email with a link to view a recording of today's presentation after the webinar. As I mentioned earlier, we're excited to present you with today's webinar on the role of AA&NHOPI serving health centers in reducing health disparities and promoting health equity. Over the course of this webinar, we're going to provide you with an overview of patient demographics, health utilization, and patient health outcomes at these health centers. We'll also highlight some differences between these health centers and other health centers across the country. And finally, we're going to discuss the implications of these key trends, findings, and opportunities to improve health care delivery and outcomes at these health centers. Joining us, their presenters today are Twin Tran, AAPSHO's Technical Assistance Program Manager, Rosie Chang-Ware, AAPSHO's Director of Research, Isha Worthingha, AAPSHO's Director of Policy and Advocacy, and Jen Lee, AAPSHO's Director of Community Services and Partnerships. Before I hand it over to our presenters, I wanted to provide you with a quick background on why we're focusing on these populations today. So as some of you may know, Asian Americans, Native Hawaiians, and other Pacific Islanders, or AA&NHOPI for short, are among the fastest growing and highly diverse minority groups in the United States. In 2012, there were approximately 18 million of this population, and it's expected to triple by 2050. This population also represents more than 50 ethnic groups in over 100 languages. To give you some more context, this is a graph showing AAPSHO's health centers, and as a reminder, AAPSHO has 24 FQHCs, or federally qualified health centers, and in 2013 they served over 450 patients, 70% of which were AA&NHOPI. Here's a quick snapshot. And another example of why this webinar is even more timely. Our member FQHCs also serve a large percentage of limited English proficiency patients. In 2013, half of AAPSHO's patients were best served in the language other than English. For some AAPSHO members, LAP patients represented up to 99% of their patient population. And here is a graph showing the growth of AA&NHOPI at health centers. Approximately 1 million AA&NHOPIs received care at FQHCs, about a 118% increase between 2005 and 2014, which is a huge bump. So this is why we're focusing our webinar and we're doing a spotlight on these health centers today. With that, I'll hand it over to our first presenter, Twin.
Thanks, Bev. For my portion of the presentation, I will be sharing a few key findings from our recent research report on all HRSA-supported federally qualified health centers, or FQHCs. Next slide, please. As Bev mentioned, to help us advance a better understanding of the Asian Americans, Native Hawaiian, other Pacific Islander communities, or ANHOPIs for short, served by federally qualified health centers, and to identify priorities and opportunities to improve health, our research study sought to gather information on patient demographics and utilization of health services at these ANHOPIs serving FQHCs, and also to examine any differences between those serving ANHOPIs and the national average FQHCs. Next slide, please. So for our data set, we examined data from the Uniform Data System, or UDS for short, for the year 2013. For those not familiar with UDS, each year all HRSA-funded FQHCs are required to report on their performance to this data set. It contains a core set of information on the operation and performance of FQHCs. For the year 2013, the total number of FQHCs reporting to UDS was 1,202. Our target population, and what we mean when we say ANHOPI serving FQHCs, are those that serve 5% or more ANHOPIs, equaling to a minimum of 1,000 patients. We chose the 5% threshold since ANHOPIs represented about 4.8% of the population based on last census data count, and also about 4.9% based on last UDS data count. And really, in practice, serving a subpopulation larger than 1,000 will really have an impact on the organization's resource allocation for culturally competent services. And additionally, to account for the smaller FQHCs that do not meet the 1,000 patients threshold, we included in our analysis those that served at least 25% of ANHOPIs. And for this data set, that number is actually quite small. There were only 4 of those FQHCs that met the 25% threshold. Otherwise, the rest, 108 of them, were having at least 1,000 patients or more. We calculated averages using raw UDS data, and 2 sample t-tests were conducted to determine significance for comparisons. And also, just a note that the limitation is that UDS data is a summary data set. It's at the FQHC level and not at the patient level. And also for ease of comparisons, we used averages. Next slide, please. So here, of the 112 FQHCs that are ANHOPI serving, they were spread across 27 U.S. states, 3 U.S. territories, and 3 other territories. Here on this slide, we present the top 5 states in terms of the number of ANHOPI served, as well as the number of FQHCs serving them. So California, Hawaii, New York, Massachusetts, and Washington. Next slide, please. In terms of patient numbers, ANHOPI serving FQHCs have a greater number of average total patients, a greater number and percentage of ANHOPIs, and also a higher percentage of patients best served in a language other than English. Here you can see it's 33% at ANHOPI serving FQHCs compared to 23% at the national average. Next slide, please. For other patient characteristics, the percentage of those at or under 2% to 100% poverty level at ANHOPI serving FQHCs is higher slightly at 93.01% versus 92.78%. And I want to note here that even though the numbers are so close, the difference is still statistically significant and important to note since the ANHOPI FQHC sample size is much smaller than the national FQHC average sample size. And lastly, you can see here that the percentage of uninsured patients are lower at ANHOPI serving FQHCs than the national average. Next slide, please. as for clinical diagnoses, we see here that ANHOPI serving FQHCs see a greater percentage of prenatal patients, patients with Hep B, Hep C, TB, asthma, and patients with abnormal breast and cervical findings. And I want to note here that the greatest disparity is seen for hepatitis B diagnosis, where the percentage is 4 times greater in ANHOPI serving FQHCs when compared against the national average. Next slide, please. In terms of utilization, we compared average total encounters as well as enabling services encounters and total enabling services costs. Average total encounters is about 45% higher amongst ANHOPI serving FQHCs, with the most notable differences in enabling services encounters and enabling services costs. So I want to point your attention to the average total costs related to enabling services for ANHOPI serving FQHCs. It's almost double the national average, so 1.8 versus 958, basically. Next slide, please. So we dug a little deeper into enabling services and saw that the average total enabling services full-time employees, or FTE equivalents, are much higher in ANHOPI serving FQHCs. As you can note here, for interpretation staff FTEs, it's 3 times the national average. And I think this is in line with what we saw earlier, where the percentage of patients best served in a language other than English at ANHOPI health centers is much greater than the national average. Next slide, please. And then when we look at quality of care measures, we see that the percentage of patients with cervical cancer screening is higher in ANHOPI serving FQHCs, as well as the percentage of patients with controlled hypertension. And again, the percentages are really close, but it is still statistically significant and really worth noting since the sample size amongst ANHOPI serving FQHCs is much smaller. And finally, you can see the percentage of diabetic patients with HbA1c greater than 9 is less than that of the national average. Next slide, please. So for a ton more information and really great holiday reading, you can read the full report on our website. You can find it under the Resources tab, or I've included this link to get you to the report directly. And with that, I'll turn it back over to you, Beth.
Thanks, Twin. Thank you for outlining that great information. So this next portion of our webinar today, we're going to go into, given these findings, what are the implications for research policy and for health centers? So this first portion, I'm going to hand it over to Rosie, who's going to go over the research implications. Rosie?
Hi, everyone. Thanks for joining us today. So now I have the pleasure of speaking with you about the research implications and recommendations of the report. Make sure I have, let's see, can I move these slides? You can go on to the next slide. So this report is really an excellent start that gives us a lot of food for thought, but also points to the need for further investigation using additional data. So for example, we need further analysis with patient-level data versus health center data in the UDS. That's used in this report. And patient-level data can also get at collection of disaggregated AA&NHOPI ethnicity data, since the UDS doesn't report the detailed ethnicity for AA&NHOPIs besides Asian American, Native Hawaiian, Pacific Islander, those 3 categories. It doesn't break out these groups further. And as I'll discuss further, we also need data to support analysis with enabling services and social determinants of health, such as language, poverty, and education. to be able to better understand the impact of health centers on health disparities and outcomes, and ultimately to be able to prove the unique value of AA&NHOPI serving health centers. Let's see if I can move these now. If you could go on to the next slide. Great, thank you. So these types of data that I just mentioned can really help us inform studies that can help with our theoretical framework that we're proposing. So one of our theories at APTSHO is that AA&NHOPI serving health centers achieve the triple aim goals of improved population health, improved patient experience and quality of care, and reduced costs through the provision, if you could click on the next, through the provision of high-quality culture and linguistic appropriate services. Love the animation that you can do nowadays. And if you could go to the next slide. So let me go into further detail about APTSHO's theory. We know, if you could click on, let's see, do I have control yet? Okay. These AA&NHOPI serving health centers serve high-risk minority patients, that is, those that are LEP in poverty, on Medicaid, and face comorbidities like Hep B, as we saw in this report. Because of their high-risk patient base, they're required to provide culturally and linguistic appropriate services, including enabling services, to provide appropriate access to care. These cultural linguistic services, or CLAS, attract high-risk patients who continue to visit these health centers, even when they have options to go elsewhere, especially now given ACA. For example, we've heard common cases from our AA&NHOPI serving health centers that patients travel all the way from Ohio to our New York Health Center just so they can receive these cultural linguistic services. That is, services from a care team that speaks their language, understands their cultural background and nuances in terms of healthcare practices and traditions, and are just more culturally sensitive and empathetic to patients in providing care. Because of this, the care teams are more understanding of culturally appropriate treatment options for patients. Due to the demand for CLAS at these minority-serving health centers who continue to serve high-risk patients and provide value for them, health centers require more resources to care for these high-risk patients so they can have the adequate resources to provide critical preventive care before it's too late, when patients may turn to ERs for care. If you could click on the next. Let's see, do I have control yet? Okay. So these CHCs, for example, require multilingual and multicultural staff to help with their care. And this in turn leads to higher FTEs for enabling service personnel to account for the longer time needed to treat these high-risk patients. If you can go on, let's see. Oh, there we go. Do I have it now? Great. So this again leads to higher FTEs for the enabling service personnel, as reported in this, report. However, these upfront resource costs for health centers are an investment in preventive quality care, again, as demonstrated in this report, including the cervical cancer, hypertension. Let's see where I am here. Okay, great. Wonderful to have control. Including the cervical cancer, hypertension, and diabetes, and really an investment in reducing health disparities and ultimately save the healthcare system over $1 billion each year. And overall, these services achieve the triple aim goals of improving the health of populations, improving the patient experience of care, including quality and satisfaction, and reducing the per capita cost of healthcare. Okay, let me move on to the next slide. So overall, this cycle really continues. Patients come to expect these services and learn to come in for preventive visits as health centers instead of going to the ER. And the health centers must provide these cultural linguistic services, including enabling services, to get the high-risk patients into the door for preventive services. And when we do cultural linguistic services, there are greater staff demands, like the multicultural, multilingual staff, providing often challenging treatment for high-risk patients, but they are the best and most appropriate to provide this care because they have the cultural sensitivity and knowledge to do it. With greater staff demands comes a need for adequate resources to cover the costs of enabling services provided. And with these adequate resources, we can continue to provide higher quality of care, achieving these triple aim goals. So to be able to prove this theory, we need to collect and document appropriate data. First, we all need to collect and advocate for the collection of disaggregated AA&NHOPI data. We know that, at least those in the AA&NHOPI world, we know that aggregating AA&NHOPI data really does a disservice to these populations as a whole. America is really home to a large concentration of very distinct Asian American, Native Hawaiians, and other Pacific Islanders. For example, just to give some examples, Lao and Hmong have very low levels, some of the poorest levels of poverty, language, educational attainment, and face unique language barriers. And a lot of people may not even know they exist. So the stereotype and aggregation of AA&NHOPIs as a model minority really obscures any real knowledge about AA&NHOPIs with a blanket assumption of success. This perception of universal success among AA&NHOPIs results in many, especially the smaller AA&NHOPI populations, being overlooked and underserved, resulting in health disparities. So we all need to collect disaggregated AA&NHOPI data, and we cannot see these disparities in the UDS because it does not separate these groups in the quality of care reports that are, again, aggregated within the three categories, AA, NH, and PI. We recommend using the AA&NHOPI categories as written in the census as a starting framework. Second, we need to collect social determinants of health data. We always hear anecdotes from health centers that they serve high-risk patients, but we really have no data to prove it. By collecting social determinants data appropriate for AA&NHOPIs and other patients of color, we can provide evidence to payers that these patients are indeed high risk. And for this data collection framework, we recommend using our Prepare data collection tool. And third, as AA&NHOPI serving health centers, we really need to document all the unique and additional enabling services provided by our health centers, as well as the effectiveness and value of these services we provide so that we are given credits and adequate resources for these services. Our report clearly showed that AA&NHOPI serving health centers require and expend higher FTE resources to cover the cost of these enabling services. We need to be able to prove why we're doing this via the social determinants data, as well as what services we're providing via the enabling services data so that we can truly justify the cost of these important services. And for enabling services data collection, we have developed the Enabling Services Accountability Project data collection system as a resource. Finally, we need to collect patient-level data together, as many national data sources out there, including the UDS, does not collect data on the patient level, particularly with AA&NHOPI disaggregated data, but only on the CHC level. Okay. One of APCHO's solutions to this data problem is to expand our data warehouse that collects all the required data, including patient-level data, with disaggregated AA&NHOPI subgroups, as well as enabling services and social determinants data. Overall, with our data, demonstrating that our patients are high risk will help AA&NHOPI serving health centers justify payment for treating a greater amount of these patients who require these cultural linguistic services compared to other providers. The social determinants data can be used to justify the costs for cultural linguistic services, including enabling services, and help prioritize enabling service interventions, leading to greater cost savings. The social determinants data is also important to conduct risk adjustment analyses to really level the playing field between all providers, particularly for providers such as health centers who really see higher risk patients. The premise being that these AA&NHOPI health centers see higher risk patients and thus should be paid more than other providers for the cultural linguistic services, those valuable services, compared to those providers who serve less risky patients not requiring these cultural linguistic services. So these cultural linguistic services and enabling services may appear to be resource intensive at the outset, but overall, we know that they provide more effective cost savings through less emergency room utilization and hospitalization, achieving the goals of the AAA Health Equity Framework. So in order to prove our theory of what we've all been saying anecdotally, we need all health centers to get in the habit of the culture of data by documenting these important and valuable health center services. We think that by documenting their social determinants of health risks, we are also providing patient-centered care, which is our main goal, and by doing this, we better understand the patient perspective. So overall, this is why we continue to make we're continuing to make the following related recommendations as stated in the report, including the implementation of the cultural linguistic services, collection of disaggregated data, adoption of nationally recognized standards on both enabling services and social determinants, as well as ensuring adequate and sustainable payments for health center services. Thank you.
Thank you, Rosie. Thank you for highlighting why it's important for health centers to make it a part of their culture to collect data. This is really important, and it's a great segue into our next presenter. Isha is our Director of Policy and Advocacy here at APSHO. Isha?
Thank you, Beverly. Hi, everyone. I'm just going to go over building on Beverly's, Twins, and Rosie's presentations on the background, the results of the report, and research implications. Next, we have to think about, now that we have these tools, how are we going to take action? So I'm going to talk about the policy recommendations, talking about the recommendations that Rosie had outlined in the report, and then how to apply those recommendations to policy, talk about what we're doing, an overview of what we're doing so far in the policy shop at APSHO, and give you all an overview of what needs to be done to address those barriers and gaps, to incentivize those services and reimburse those services. So next slide, please. So the first recommendation, as Rosie stated, is to implement culturally and linguistically appropriate services. So we really need to show that language services and culturally competent services are not just an issue that uninsured populations face. This is an issue that limited English proficient individuals face that have that seek all types of payers, not only those who are uninsured. So within the administration, we have been advocating to prioritize language for the Affordable Care Act within outreach and enrollment activities. So we have been looking at not only materials, to provide materials in language, but we also have been advocating that in-person assisters and certified application counselors, as well as the care coordination team, is able to provide these services in language in order for patients to be able to enroll in care, in the care that they actually need. So we've been really focusing on that in the past 2 years, but our focus at APSHO is changing from outreach and enrollment towards coverage to care, as we're seeing that many health centers are having issues with their patients actually being able to, now that they're enrolled, they are having issues with actually being able to access the care. So as we do that, we move that focus to coverage to care. We're trying to ensure that language is considered within QHPs, which are qualified health plans, to ensure that qualified health plans are considering the many languages that their patients speak, that materials are included in language, and that providers within these qualified health plans speak the languages that the patients speak. Overall, we are also trying to ensure the implementation of HHS, the Department of Health and Human Services, rule of Section 1557. That is the non-discrimination rule in health programs and activities. The proposed rule was released a few months ago, and we hope to see the final rule later in 2016. So we want to ensure that 1557 includes language access services, that includes the fact that providers are able to provide culturally competent services, and that it reflects class. So I'll talk about class in a couple slides. So we just want to overall ensure that the culturally and linguistically appropriate services are not only ensure that they are not only what's good for patients, but they overall improve the entire health system. So next slide, please. The second recommendation is to collect disaggregated data on NHOPI to better identify needs and priorities. So we heard a lot already about the importance of disaggregated data. As Rosie had stated, we continue to advocate for disaggregated race and ethnicity categories. In DC, where I am, we continuously run into roadblocks with trying to disaggregate race and ethnicity categories in national data sets. This is because national data sets look to the race and ethnicity categories stated by the Office of Management and Budget. So we advocate that race and ethnicity categories at least reflect the census as Rosie had stated, which are very similar to the Affordable Care Act, Section 4302. So those race and ethnicity categories for Asian Americans include 7 Asian American categories and 4 Pacific Islander categories. The difference between the census versus 4302 is that the census includes a write-in category for both Asian Americans and Pacific Islanders, which is the standard that we'd like to see in all national data sets. Next slide, please. So the third recommendation is to adopt the nationally recognized standards on enabling services and the social determinants of health to prioritize interventions and justify reimbursement. So we continue to advocate and support policies for the adequate and sustainable payment of critical non-clinical services. So it includes enabling services, and we want to ensure that the class standards, so those are the national standards for culturally, linguistically appropriate services, are integrated so that those standards were finalized recently, a couple of years ago, but we want to ensure that those are actually implemented. So we've been doing that by working with a number of federal agencies within the Department of Health and Human Services, and we want to standardize social determinants of health collection through, for example, the Office of the National Coordinator, through EHR systems, as well as others. Next slide, please. The fourth recommendation is ensuring adequate and sustainable payment for enabling services. So this is one of the primary policy goals of APCHO. With that, we want to support alternative payment methods that are inclusive of enabling services provision. It's incredibly important to not only protect the systems already in place, like the prospective payment system for Medicaid, but that alternative payment methods also include risk adjustment for language, social determinants of health, and enabling services, like Rosie had mentioned earlier. We want to ensure that better reimbursement rates for spoken and written enabling services are incentivized, particularly for those payers that aren't properly reimbursing FQHCs. We continuously see this anecdotally and with our member centers that the amount of services that they provide are not being reimbursed for the complex patient populations that they serve. Next slide, please. So the fifth recommendation is to dedicate funding and payment for recommended preventative services for Hep B, Hep C, and tuberculosis to improve health outcomes. So as Twin had presented earlier, the rates for Hep B, Hep C, tuberculosis, asthma, diabetes, and more health issues are much higher for NHOPI serving health centers than for the health center population at large. With that, one way that we can work on that in policy is to ensure that the implementation of recommended guidelines are paid attention to and that they are adhered to by different payers. So just because the guidelines have been released by the U.S. Preventative Services Task Force, when they are released with either a grade A or a grade B, they are considered to have no cost sharing in for the health insurance marketplace. But that does not necessarily mean that they're implemented for Medicare and Medicaid. Those processes need to be done separately, and we're realizing this, for example, with both hepatitis C and hepatitis B, that the process needs to happen separately for Medicare with applying for a national coverage determination, and then Medicaid becomes more complicated because that's state-based. So we continue to push this angle and to ensure that our APCHO member center patients are covered for these very important preventive services to ensure that larger, more severe health outcomes do not occur down the line. With that, we also want to promote the expansion of evidence-based care models for addressing disparities. So particularly with these health issues that I mentioned earlier, the chronic care model, health homes, and the patient-centered medical homes are incredibly important to serve those patients facing multiple barriers and social determinants of health that have the complexities that were mentioned earlier as well. Next slide, please. So the last recommendation in the report is to dedicate funding to support and sustain the research infrastructure and the submission of data to a centralized data warehouse. So Rosie had spoken about this earlier, but again, as I was mentioning earlier about the importance of disaggregated race and ethnicity, it is the more granular data that we get, the better able we are to advocate for the patient population that NHOPI serving health centers serve. So that's looking at the social determinants of health and race and ethnicity. The premier issue that we deal with, particularly as we're talking to the administration, health agencies, and other partners, is that if we're not able to fully represent our populations adequately, others who don't know our populations will end up doing, will end up speaking out for us. So we need to ensure that the data is as granular as possible and represents the populations that NHOPI serving health centers serve. So the implications of that, besides what I had stated earlier, is that more granular data and the incorporation of social determinants of health data collection will impact those alternative payment models in terms of risk adjustment and the complexity of alternative payment models that NHOPI serving health centers need. It's better able to show the services that member centers provide to give us a better picture and to be able to advocate better. So thank you so much.
Thank you, Isha, for that very helpful overview of how these implications really do have an impact on the local, state, and federal level. And our next presenter is Jen Lee. She is our Director of Community Services and Partnerships here at APCHO.
Great. Thank you, Bev. Good afternoon, everyone. So I'm going to talk a little bit about some of the tools and resources that we have available here at APCHO that may be of use to you related to the content we discussed today in today's report out. Next slide. So just a little reiteration. So APCHO actually is a national cooperative agreement with the Bureau of Primary Health Care. So we are really tasked and available to provide training and technical assistance for FQHCs serving existing or growing AA&NHOPI populations. Our current programs really aim to focus on increasing the ability of FQHCs to provide culturally and linguistically appropriate care, manage their population health, and then therefore reduce disparities and improve health outcomes for their populations, and in particular to NHOPI serving patients that may be growing or existing or dominant in their health centers. Next slide. So I'm going to talk a little bit about some of our current programming. We've really here been focused on the development of several tools and resources that can assist FQHCs to both evaluate and build their capacity to enhance data collection and also operationalize best practices in cultural and linguistic competency for ANHOPI populations as well as limited English proficient populations. Some of the things I just wanted to highlight for the group are one, just a class self-assessment tool that we've developed to help boards and health center leadership better assess the areas of strength and their growth of their potential growth in supporting class-appropriate services at their health center. It's important to start with leadership to get a concept of class in your health center to know how your programs are going to be directed and what data you're going to need to design those programs. Next, I wanted to share, we have a Crosswalk tool that we recently launched that is also aimed to help health centers better understand how and where your health center program requirements intersect with NCQA, PCMH, or patient-centered medical home standards, and how they also then align with class standards. I think this is an incredibly helpful tool to kind of translate all the overlap that occurs. So this can really help your health center with identifying where you're already meeting or where you can work towards meeting more of the class standards and where you can prioritize your future efforts to provide more culturally and linguistically appropriate services. Third, as my colleagues mentioned, APCHO has nationally recognized tools and training and technical assistance in enabling services and the collection of social determinants of health data. And all of that is, as Rosie mentioned, kind of in an effort to build towards, I think, a data warehouse where there is patient-level data available in which FQHCs and partners can better address health disparities and also look at the costs of the critical services, including enabling services that really we know now lead to positive patient outcomes. As some of our next steps, next slide. Some of the things that are coming up at APCHO we wanted to keep you all aware of is we are launching a listserv for ANHOPI serving community health centers. And to join that listserv, we have the email address here. We want to keep the dialogue going with this growing base of ANHOPI serving FQHCs nationally. We also have a couple of upcoming webinars subsequently in January and February that will be focusing on our enabling services and social determinants of health, data collection tools and efforts, and then also how this unique work has impact and what is happening for ANHOPI CHCs around addressing health disparities like hepatitis B, as Twin mentioned earlier. We also are excited to be launching a national class survey. So we'll be working with a similar pool of the 112 health centers that were identified earlier, as mentioned in the report, to really identify what best practices they have in place, what policies or procedures they have in place to help them measure and or indicate and document their efforts towards class and development of class-centered services. We're also excited to be planning a ANHOPI Health Summit in Atlanta, Georgia during API Heritage Month this May, or May 2016. In the South, ANHOPIs are one of the fastest growing populations nationally, so we are excited to have that be a platform for, again, more national training resources and to provide hopefully an update from the class survey national report there as well. So those are a couple of things that are upcoming we'd like for you to save the date on. And I'll go to the next slide. And also just want folks to note some of the great links. Of course, a lot of these great resources are on our website at www.apcho.org. Our Enabling Services Data Collection Protocol link is here, as well as our Social Determinants of Health data collection information. So I know these slides will be available shortly, but please note these links and please take a look at them, share them with your colleagues, and contact us because we want to stay in touch and involved with you. With that, I will hand it back over to Beth.
Thanks, Jen. And after all of that great information, we're eager to hear from those on the phone. We will now begin the Q&A portion of our webinar. Again, as a reminder, to participate, you may submit your questions in writing by typing them in the questions field on your control panel. And it looks like we have our first question, and this is probably for you, Jen. Could we get a link to the APCHO programming tools?
Yes.
Yes.
We
So,
just said no.
okay.
Good question, yes.
All right. Our next question might be either for Twin or Rosie. How and why did you decide on the 5% cutoff or threshold?
Again, we mentioned we chose the 5% threshold to be representative of the ANHOPI population generally. And so based on census data, it was about, ANHOPI represented about 4.8% of the population. And then for the UDS data set back in 2013, ANHOPI represented about 4.9%. And really in practice, serving any subpopulation that is larger than 1,000 will have an impact on the resource allocations that you make, and also on the need for providing culturally and linguistically appropriate services.
Thanks, Twin. Our next question is, are you saying that all health centers should collect disaggregated ANHOPI data? And if so, how do we address getting disaggregated data for some health centers when some of them may not have these large patient populations? Rosie, did you want to take a stab at that one?
Sure. Thank you, Bev. That's a great question. I think we still indeed need to advocate for this AA&NHOPI data collection, even at these health centers that may not serve as higher populations of AA&NHOPIs. Otherwise, if not, we really perpetuate the model minority myth that these populations are successful. So even if these health centers may not serve a lot of these AA&NHOPI populations, it brings a lot of awareness to these. By collecting it, it brings a lot of awareness to these smaller, unnoticed populations who are indeed even higher risk because they are a smaller population. Just maybe to give you an example, just like with a lot of the sexual orientation, gender identity data that is, has plans to be put into the UDS and required for CHCs to report on, these patients will become less masked as their racial ethnic identity is reported more globally, and with the identification of higher numbers or unmasking of these populations, we can better justify resources to help these high-risk populations.
Thank you, Rosie. We have another question here. How does your enabling services data collection differ from that of UDS?
So this is Twin here, and the UDS collects a more limited set of information on enabling services. And what our tool does is it enables health centers to document the time and effort that the health center spends in providing enabling services to their patients. And also it collects information on the patient, on the service provided to the patients as well. So you'll be able to carry out research to determine if that enabling service intervention is really addressing or meeting the needs of your patients. And for more information, as you can see earlier, next we'll pull up that slide again for the link to the data collection protocol.
Thank you, Twin. This question is for Isha. Isha, if someone wanted to get involved on the policy side of things, what would be a way that they could, or the first step they could take?
Talk to me. I'll try to figure out a way that you could get involved. There are a number of coalitions. It depends on what area you're interested in, whether it comes to data collection or if you're an APSHO member and you want to get involved. I'm happy to point you to different resources that you can work on to get involved. Or if it's on the preventive services side, there's a few coalitions that are working on those initiatives as well to ensure that the guidelines are implemented. So my contact info is on the in this webinar, and please feel free to contact me.
Thanks, Isha. And this is for all the presenters. Jen went over a few dates during her section, but are there any key dates coming up that folks should look out for if they're interested in any of the information that was presented today? Jen, you had mentioned that there's a few upcoming webinars, and I think that there's some research webinars as well. Rosie?
Yes,
did you want to mention
actually, just to talk a little bit more about our Prepare project that I and Jen had referred to earlier. You know, we're working with the National Association of Community Health Centers, Oregon PCA, and the Institute for Alternative Futures, and we had piloted this social determinants data collection tool with 4 learning communities, health centers or health center networks, and we're actually finishing up this pilot, and so we'll be we're actually getting more into the data now, which we're really excited about. But also, we've been getting lots of requests for webinars for social determinants, as well as enabling services. And so once we get a better sense, and we are doing some of them, some of those now, and having conversations with folks, but the more formal ones, we are interested in launching some webinars based on the 4 common EHRs that were implemented during our pilot this year, and so we'll be working to develop and work with the health centers on the ground that developed this, did the implementation of the social determinants data collection, to bring to you webinars that will showcase the experience of the data collection and feature the data collection tool for social determinants of health. And so you could attend that based on your EHR platform. So if you'd like more information, you could look at that social determinants data collection website, or you can contact me, or I can get you the contacts at NAC as well.
Thanks, Rosie. This is Jen, too. I just wanted to clarify on the social determinants of health data collection tool that is a robust effort in partnership between APCHO, the National Association of Community Health Centers, the Oregon Primary Care Association, and the Institute for Alternative Futures. And that whole effort has been funded through the Kresge Foundation, Kaiser, and Blue Shield of California. So we're excited to have a real national platform and partners to roll out this tool. So there's quite a bit of work and effort gone behind it. So please check out the link.
Thanks, Jen. We have one last question. And again, if you have questions, you can type it into your questions box there on your control panel. This next question is, what is the total number of patients in your data set?
So for 2013, all UDF patients served was about 21.7 million patients. And within our data set of 112 ANHOPI serving FQHCs, there were 2.8 million total patients. And of those total patients, 600,000 are Asian American, Native Hawaiian, and other Pacific Islanders. So this really is why, even though some of the comparisons seem to be close, it is still statistically significant and important to note because of the difference in the size of our sample set.
Thank you, Twin. And that is all of the questions, I think. If we weren't able to get to your question today, you can always follow up with us over email. You can also find more information on our website, www.apcho.org. And this slide has all of the contact information of the presenters today. Lastly, I would like to thank our presenters and thank you all for participating. Please keep a lookout for an email from APCHO, which will include the materials from today's webinar as well as future opportunities to get involved. Thank you all again, and have a great day.
Okay, thank you.
Thanks all. Happy holidays.